So in some ways, you could argue this is a lot of low tech, right? This is low tech, using some data, some algorithms to get these patients, but then you're talking about using people to contact patients. And what's the effect? Well, over the span of 6 months, we saw that in the control group, the rate of colonoscopies was pretty much staying around 80%, but in the intervention group, it climbed all the way up to 88%, right? So a really dramatic difference. So this study actually went so well that Partners Healthcare said, you know what, we want you to do this whole thing, this sort of population management for the entire population at Partners, which meant that we went from 70,000 patients to about 300,000 patients, and instead of one single condition like colorectal cancer, it was across multiple conditions. So we're going to manage all these conditions for 300,000 patients. To do that, it actually took a huge number of practices, many physicians, delegates, practice managers, diabetes champions, navigators, about 1,500 people within our whole enterprise to be involved in this. At the end of it, all the quality measures improved. So every single one of these went up by anywhere between 2% all the way up to, I think the LDL lipid measure went up the highest to 8.5%. And even though those seem high, they were coming off of a pretty high base, right? So some of these were already quite high, 81% going to 89%. So it wasn't something coming, if you're coming from a very low percentage, it's pretty easy. But when you're coming up from these pretty high numbers already, it's hard to get these kinds of increases. So it was really pretty dramatic. If you do an analysis of this in terms of what the change was in terms of control or improvement, you could do a number needed to treat analysis to find out that, in fact, because you've avoided a lot of comorbidities, you can calculate the estimated cost savings across all these diseases. And at the end of the day, it was estimated about 76 lives were saved. This is over the span of 4 to 6 months. About $3 million in treatments were avoided. Things like cardiac catheterizations, amputations for vascular complications of diabetes, et cetera, et cetera. And it was calculated that it cost about $7 a patient to run the whole process, and it saved about $20 a patient. So in the end, it was not only was it a good thing to do, it was also a cost-effective thing to do. So some of the ongoing care delivery initiatives we have now, we're looking at things like crowdsourced decision support, so using other people's decisions on treatment to help inform prospective treatment for other clinicians. Knowledge-based data retrieval, we want to look at how we can use knowledge to improve how clinicians can pull data out of the electronic health record. So instead of just looking for information, explicitly, the system can actually say, based on what this patient's disease context is, I can show you information that you're likely to want to know. We're looking at automated patient follow-up and surveillance, because we know one of the biggest issues is that when patients have a plan of treatment, they don't often keep it. And so you really need to keep track of what's going on with patients when they're going down a high-risk plan. And then finally, we're looking at mobile conversational user interfaces, because frankly, doctors hate using computers and electronic health records. So if we can create something where they can talk to their phone and pull up that last MRI, or ask about specific information from the record and have it pull it up, that'll be terrific. So thank you very much. This is just a quick run through of some of the things we're doing at the lab, and I really appreciate your time and happy to take any questions.
Great presentation, and I'm very jealous about all this database. Yes. And any questions for Henry?
So Henry, I'm just more curious about, it's so good that all the measurements, or say the entire systems, help to address the issues of the patients much earlier than it happens, right? By collecting all these data, right? So I'm just curious about, how do you see Taiwan, as we have a kind of a well-known or say will recognize the national insurance health system that collect our patients' data among hundreds of thousands of clinical organizations on a daily basis. How are we going to kind of have, I don't know, exactly if in our system there's any preventive measurements are taking or tracing patients' data for prevent the diseases happening or getting even worse, right? But how do you see that if we have a nationwide system in place, right? How are we going to utilize the concept that you have adapted there in Boston area, right, and in Massachusetts, and then apply into our system where data are probably available already?
Yeah, I think that's a great question. I think that really it takes a commitment to collecting the information up front at the point of care. Like there's just no way around it. We've looked at using natural language to process notes after the fact. We know that insurance data is really noisy and very bad because people will check things off for billing purposes, not for clinical purposes. Yeah. So at the end of the day, I think if you have a national commitment to gathering the kind of information you need to warehouse, right, for these kinds of efforts, that's the only way to do it. And so whether it's through electronic health records, whether it's through companion type applications that patients could fill out some of this information, and you could have maybe even non-physicians validate the information so it doesn't take too much of the physician time. But at the end of the day, you need to capture those attributes up front so they're reliable and validated. Yeah.
And do you see any problems? I mean, how this kind of concept or system or platforms being adapted in the United States is only at the state government level, or is also federal governments are paying attention to it and then adopting this kind of a concept of platforms?
Yeah, I think that, I mean, we've certainly seen different groups around the country and the world use, say, the I2B2 platform to collect this kind of data. It's always a challenge. I think in every, all data is local. So it's a challenge to get your own local community to be comfortable with the collection of this kind of data. Because over time, it extends into, genotyping and genomic data, and that can be very sensitive. So it's as much a policy and social issue as anything else, frankly.
So what about the attitude or position of federal government in the United States?
Well, I think the federal government in the US is still very much protective of patients, and so what we've had to do, for example, at Partners Healthcare is we've gone from a opt-in policy where patients would have to be contacted to allow their data to be used to an opt-out policy where if you come to get treated at Mass General, unless you opt out, you're basically opting in to allow your data to be used in a de-identified way, right? And I think more and more systems are taking that approach because it's really the only way to do this at scale.
I see. That means you need to have the open-minded regulator behind you supporting this.
You do. And you have to also have other laws that protect patients and consumers, right? Because if you open it up too much and then you don't have laws protecting your population, then you start getting things like health discrimination, basically.
So for your project, it's actually outside the scope of federal regulation, is it?
It is, yeah. We're not really tackling that level, yeah, but we're certainly aware of it.
It's safe. Okay, more questions? Okay.
Hi, that's a very informative talk, thank you. And I have a question for you because it happens to be that I have the opportunity to make suggestions for our NHI health system that they are embracing an open data strategy recently. But I think that is something that's very sensitive because embracing open data means that they have to deal with all the privacy issues in the identification. And I was wondering that have you have some sort of this type of experience that you can share with us about how to do it?
Yeah, so it is very challenging, and I mean there are a couple of ways. I think one thing is to stage data, and you heard that a little bit here, which is that you can create different barriers, if you will, to getting identifiable data, right? Because you can start with aggregate queries. So the reality is if you do a query across an open data set and the numbers don't meet your need, then you don't need to get the identified data, and you've actually prevented pulling data that you don't need, which is always a big problem. Then the next level might be that you might expose certain parts of the data, but not all of it, so that you can again decide which part of the data set you really need. So I think one of the basic tenets is, if you can provide at every step what the investigator needs to decide whether they actually need to unmask all the data and identify the patient, then that'll help a great deal, because they're going to only unmask the patients that they really need, right? And people are much less concerned if you can guarantee this very high degree of specificity, right? We're only going to pull in the patients who really have this disease in this context. We're not going to pull in, 50,000 other people who aren't going to benefit from what you're doing. So that's my main, my main recommendation.
Thank you, Professor Chueh. And I'm a doctor, and most clinical doctors are afraid of legal problem. So I'm wondering if the machine, the system tells the patient is okay and the patient can go home. But 1 month later, now the doctor say he has a cancer, and who will take the responsibility?
You will. No, it's a really good point. So I think one of the ways that we're thinking about this is sort of the difference between virtual reality and augmented reality, or the difference between what do you call level 5 automated cars and level 3. So I think the systems that we're looking at are augmenting clinical, clinicians, right? So the goal isn't to say that the system's going to tell you what's right and then you're going to just follow it, because frankly, if it was that good, you wouldn't need the doctor, right? You could, for those conditions, you could use someone who doesn't cost so much and isn't so trained. But we want systems that actually help the doctor be a better doctor, right? So it helps you ask the question that you wouldn't have asked, but then ultimately you're going to be the one to still make the decision, because a lot of times it's not just about the diagnosis. As you know, most of the time it's about, well, we know the diagnosis, but now we have to talk about the different options for treatment, and that has all to do with patient preference and social context and many other things that, I suppose in 7 years maybe when we get super intelligence, it'll do everything. But I think those kinds of patient-oriented issues will remain in the realm of doctor-patient relationship. So my son tells me, when I tell him, oh, here's a hard problem, he always says, you mentioned the Kurzweil book. He says, don't worry, Kurzweil says that in 8 years we'll have super intelligence, it will solve everything, so I'm just going to ignore it.